Good day, everyone. I'm Dr. Carmen Pugliafido, and I'm here today with a friend and colleague, Dr. Johanna Seddon, who is professor of ophthalmology and director of the Macular Degeneration Center of Excellence at the University of Massachusetts Medical Center. Welcome, Johanna.
Well, thank you, Carmen. Appreciate the opportunity to talk about this important topic.
You've been recognized as a pioneer in epidemiology and genetics of macular degeneration. And it's amazing how this field has contributed now directly to therapeutic advances. What are your thoughts about the genetic basis of our current experimental treatments of geographic atrophy?
Well, it's a very important question. I'll just go back in history a little bit. If we looked at twins back in the 80s, using the World War II twin registry to dissect the relative contributions of genes and environment on AMD, and we found that AMD was highly heritable, with up to 70% of advanced AMD explained by genetic factors. But there was also an important environmental component of about 30%. And around the same time, in the early 1990s, we conducted familial aggregation studies to support efforts to search for the genes, and found that family members had about a threefold increased risk if one of their family members had advanced AMD. So both twin and family studies pointed toward this role of genetics. Since then, many genes have been discovered. So it's definitely an important topic. And in fact, since 2005, about 51 variants in over 30 genes have been associated with AMD. Many of these are in the complement and immune pathways, which regulate the pathway. And genetic variants lead to dysregulation and overactivation of the complement pathway and higher risk of developing AMD. So after the initial discovery of the CFH genes, our team found new genetic variants in CFH, also new genes in the pathway CFI and C3, and this is all going to lead up to what I'm going to talk about in terms of treatment. And all these common variants have low to moderate impact. Then we discovered variants in the same pathway that are rare, so they're much less common in the population, but they have very high impact, with risks as high as 20-fold higher if you have these variants. These are variants in the genes CFH, C3, CFI, and C9. And loss of function in CFH or CFI, or gain of function in C3, alters the balance toward excessive complement activation, which can lead to tissue damage. So there are many therapeutics now being tested in this complement pathway for GA. And we can go over a few of those right now, if that's would be of interest.
Yeah, I think that you provided a really excellent summary of the complement cascade pathway. And now let's talk about some specific therapeutics.
Yeah, for C3, there is a C3 antagonist, which blocks C3, this C3 protein from cleaving to form C3A, and which C3A triggers the final common pathway. So this is aimed at an antagonist for C3, and to dampen that overactivation of the complement pathway. And those studies are now in phase 3 trials. And then that's one target is C3. And then there is another target in targeting CFI by an adeno-associated viral vector, or AAV, against CFI among individuals with certain rare CFI variants. And that is delivered subretinally. For CFH, a precision medicine approach is administering a full-length recombinant CFH protein replenishment for individuals with factor H functional insufficiency and individuals with higher genetic susceptibility. So it's more of a precision medicine approach. That's delivered intravitreally. It's the only treatment aimed at restoring levels of functioning CFH to downregulate pathogenic complement activation. And moving along, in the complement pathway for CFB. There's an antisense oligonucleotide inhibitor against CFB, which is administered subcutaneously, targeting the gene expression level. And those are all genes that are known to be related to AMD based on genome-wide association studies and sequencing studies and so forth. There are other genes in this pathway that are being targeted that have not been associated with AMD per se, but they do play a role in the pathway. So those are C5. And one approach for C5 was an anti-C5 monoclonal antibody. Another approach is an anti-C5 aptamer, which is administered intravitreally, which is now in phase 3 trials. And these C5 therapeutics prevent the cleaving of the C5 protein and prevent recruitment of inflammatory cells and subsequent activation of that final common pathway. No longer being tested is another one, an anti-CFD antibody fragment that was administered intravitreally, but it did not show any slowing of GA progression in phase 3 trial, so that is no longer being tested, the CFD antibody. Then for neovascular AMD, there's gene therapy aimed at expression of VEGF and gene silencing approach with an anti-VEGF antibody. So that's another gene-based therapy with a different mechanism. So there are a lot of trials most in phase 2, phase 1, and a few in phase 3 now that are targeting various points along the complement pathway for geographic atrophy mainly.
What about the precision medicine approach? Is it realistic to look for specific variants and direct treatment to them, or are the number of patients sufficient to justify this targeted approach?
Well, that's a good question. One of the companies targeting CFH is looking at also the common variant, individuals who have the common CFH variant in addition to the rare variants. And the thought is that if there's proof of principle or effectiveness in those with known functional deficiencies in these genes, then that could maybe be applied to a broader population after that. So that's the rationale. At least as mentioned, 2 companies are testing therapies aimed at individuals with higher genetic susceptibility. And, I think that it'd be interesting to see what those results are. And perhaps that's the future, precision medicine. So just like in other fields, what is your genetic susceptibility, and aim at therapy based on your own personal risk.
You referenced some very rare variants that have 20-fold increase in disease probability. What are those, and what do you think about those as therapeutic targets?
Well, that was specifically the CFH R1210C variant, which is a rare variant with high penetrance and also causes earlier age of onset of AMD, much more likely to be familial, much more likely to have symmetrical disease in both eyes, much more likely to have numerous drusen in the macula and also outside extramacular areas. So it has a certain phenotype as well. And of all the variants discovered to date, it acts more like Mendelian and autosomal inheritance compared to all the other variants that in this disease with complex genetics. So I think that is definitely a target, and that is included in the therapeutics that is based on the CFH protein replenishment with the full-length recombinant protein. So we'll see what that shows. That's only in phase 2 studies right now, but it's definitely a therapeutic target.
Who's doing that phase 2 trial?
The phase 2 trial is being done by Gemini Therapeutics. And full disclosure, I'm a scientific co-founder of that company. I'm not employed there, but I am one of the scientific co-founders of Gemini Therapeutics.
Well, it's exciting to see basic research being translated into potential clinical changes. What about CFI and that approach?
Yes, that's another therapeutic. That's Gyroscope. I'm not affiliated with Gyroscope, but they are doing a different kind of approach, a subretinal AAV vector gene therapy approach, and they also are targeting individuals with high genetic susceptibility, individuals with certain functional CFI variants, genetic variants. So, we'll look at, follow that very closely too, to see how well they do. They're also targeting geographic atrophy.
What do you think about the approaches used by Apellis and Zymura, Apellis and Iveric, where they're really they're not using genetic susceptibility, they're really targeting either C3 or C5. What do you think about those approaches in terms of rationale and probability of success?
Well, it's hard to predict, of course, but I think the rationale is good. For C3, it's a gene that's known to be related to AMD. There are common variants related to AMD. There are rare variants in C3 that are related to AMD that we found. And, I think it's a sound approach. It's, again, blocking C3 from cleaving to form C3A, and which triggers the final pathway. And they have shown some promising results in phase 2 studies, and now they're in phase 3. So, I think it definitely has a good rationale.
What about C1q inhibition as proposed by Annexon? What about that approach? Where does C1q fit into this cascade?
Yeah, C1q, it has a little bit. It's not as definitely related in genetic studies for AMD, but again, if it's part of the pathway, then it has a rationale because it's part of the same pathway.
So, are we at the point where we need to genetically characterize our patients with geographic atrophy and dry AMD?
Well, I'm not sure. I mean, we should also think about other pathways at this point too. There are genes related to HDL, some increased risk and others decreased risk, and these genes include LIPC, CETP, ABCA1. And we know that lipids build up in Bruch's membrane with AMD. They are a major part of drusen, so maybe targeting lipid transport pathways to lead to new treatments. An important gene on chromosome 10, we haven't talked about, ARMS2, HTR1, although of uncertain mechanism at this point, that's also being targeted, especially for exudative AMD. And then there are other genes in the extracellular matrix pathway, like COL4A3, COL-A1, and others. And there are other genes in the DNA repair, protein field binding pathways that are related to AMD. There are many possibilities for targeting other pathways other than complement. So to answer your question, I think, maybe precision medicine is not standard of care now, but it could be that if any of these therapies are successful and more highly related or more successful in individuals with certain genetic predisposition, and maybe other pathways will have therapeutics aimed at at those pathways. I think it's a matter of time, actually. Right now there's no proven treatment based on genetics, right? So genetic testing isn't routinely recommended, but I predict this will change. And I think it will change. And I think it's only a matter of time, and not a long time necessarily, before genetic testing and application of, say, prediction models, predicting who will progress to advanced AMD and who will not, which are very, very good predictive models now that we and others have developed. And I think it's only a matter of time that this will be part of clinical care for AMD too.
What about, we know that there's tremendous commercial activity on the complement pathway side. On the non-complement pathway, is there commercial activity trying to develop agents?
Yes, I am not aware of there's ARMS2HR1 at chromosome 10 that I mentioned. There's a lot of activity around that. And for the genes in HDL pathway that I mentioned, or the collagen vascular extracellular matrix pathway, I'm not aware of any at this time, but there's a lot of interest in those other pathways as well. So we'll watch and see where they go.
What's the approach for the chromosome 10 related pathway?
There's I would have to actually look at that a little more carefully. But there's a gene therapy approach that's being evaluated, and there's also some interest in protein replenishment, HCR1 protein, and contrary to the approach of the antagonist toward the protein product. So it's being approached in different ways.
So you've been working on genetics of macular degeneration for decades. Are you surprised at all the progress that has been made and that we're really on the verge now of maybe having some real clinical tools?
I'm not surprised. I think it's a very exciting field at this time. It makes a lot of sense to target the biologic pathways that are involved in this disease. And the complement pathway being a major one is certainly right for a different approaches because of the complexity of that pathway and how many different genes in that pathway are related to AMD. So I'm not surprised, and I look forward to seeing the results of some of these studies as they move from phase 2, hopefully to phase 3. So.
Well, Johanna, thanks so much for your time today. And it was an exciting review of the genetics of the therapeutic approaches. And I've got to believe that something is going to work. I think we're going to have a success along the way here. We're not quite sure where that is, but I think we will. And thanks so much for your time today. And thanks for being on Retina Synthesis.
All right. Thank you, Carmen. And I appreciate the interest in this area and look forward to talking more as we get more results on these studies.